Okay, welcome everyone to the Ortho Conditioning, kind of like a podcast, kind of like weekly grand rounds, um, kind of like video where we talk. So it's all in one. You guys are getting the full experience. I'm here with Dr. Jimmy Gannon, same as 2 weeks ago, and we're here to talk
Yes.
about kind of the details of away rotations or just ortho rotations in general and how to be hyper successful. So I wanted to talk about kind of the details in regards to what made med students really stand out, what specific things are they doing, and then kind of how you can apply that to really whatever field you decide to go into. There's really lots of things that are applicable even outside of just doing an orthopedic surgery rotation.
Yeah, and thanks Drew for having me. I want to preface by saying, so I'm a first year resident, um, and one of the stuff I'll be mentioning was kind of things that were told to me by other residents, some feedback that I got kind of along my road doing 4 aways or 3 aways and one home rotation. So not just like I'm the best rotator ever, just these are just kind of tips and tricks that people have kind of given me along the way.
You've only done three aways, Jimmy. I think Fred, one of our group members, is doing six.
Wow,
So you
good for
are
you, Fred.
you are a chump rotator. So with that, let's. I should probably say, just to give people some context. I'm a fifth year resident in Grand Rapids. Dr. Gannon and I are in the same program. This whole thing, ortho conditioning, was started to help go into details about things we wish we would have known in regards to like orthopedic surgery, how to match in orthopedics, and uh, it'll be interesting to see how it evolves over time. Hopefully, a good resource for med students, residents, and maybe even attendings one day. So we just keep plugging away. So let's dive right in. Um, the first thing I have listed is give some background about what we mean by an ortho rotation. So may
Yeah.
seem obvious, but go ahead.
Um, but so I was curious. So most that I saw were like 4 week rotations that you sign up for kind of towards the end of your third year, and you sort of sign up for these the beginning of your fourth year. Did you see any that weren't 4 weeks? Were most 4 weeks for you?
Everything I saw, like I feel like it's pretty standard 4 weeks. Some people do like a 2 weeker when they're in their third year, but that's a little bit different than a typical away rotation. And really, our conversation is anytime you're doing an ortho rotation, whether it's 2 weeks or 4 weeks. But if you're not familiar with the process, when you're in your fourth year, you have to sign up to do these aways almost like a month long interview, essentially, where you go there and you just live there, spend a ton of money to live there, and then you just desperately try to hold on for the next 4 weeks to not do anything stupid.
Yeah. So I think we had touched on this last time too. You are taking 4 weeks of your fourth year, um, many times with like limited time. So you kind of want to pick your programs carefully based on what you're really looking for. And I think if people are interested in that, they should look at the last episode we did.
Yep. So going into the next question here, let me pull it up. What makes students stand out on their ortho rotation? So we just we're in the season just after having kind of a ton of aways. So we'd cycle through med students every 4 weeks, and I think we did that for 4 rotations, 4 or 5 blocks of 4 weeks.
Yeah, I think starting in July and going through November, so maybe five
Yeah,
actually. Yeah. Wow.
yeah. And it's kind of weird being on the med student side because you're like, uh, it, it's 4 weeks is feels like a long time, but it's also very short. But the time perspective is very different because from the resident side, you're doing 10-week blocks, at least in our program, and then it seems like you're getting a very small glimpse of working with one med student very briefly for like a day, and then they're gone, and then you're with someone new, and it, every away rotation is different. So at our program, people would come in and every week they go to a different service. And I don't think it's like that every way. Well,
Yeah, I had one program where I
everywhere, I
was
should say.
just I was just at one. So like this program went to multiple different hospitals or sites, and I was just at one site with one group of like six residents. It was great because I got to know them very, very well. But at the same time, kind of a double-edged sword. You don't really get as familiar with the other sites or the other residents. Maybe contrast that with a program like ours where you are somewhere else every week. So,
So, what do you think stood out, Jimmy? What really made messages stand out?
so I think we had maybe kind of touched on this earlier, but like that of anticipating and watching. So I remember when I showed up to like my aways, sort of in the first day or two, you're just kind of like taking it all in and really learning how that program does things, like how they set up the room, how they um, prep the patient, and I was just trying to like silently, quietly take in everything I could, and then from there, hopefully, you can start to kind of um, jump in and be a little bit proactive. I guess that was always sort of how my rotations started, at least.
Um, so some things I wrote down, and sorry, I'm blanking a little bit. I just had like a error thing pop up on my screen with the sound recording. So hopefully this audio is being captured the way it's supposed to. Apologize if it's screwed up, but you know, students standing out on their ortho rotation. A couple of things that I wrote down. Um, the art of anticipating. Is that one of the things you said, Jimmy?
Yeah, I think you're just kind of like learning to, yeah, like kind of anticipating, observing, hopefully being proactive eventually.
So, what do you think? What do you think? How do people do that in an effective way? Like, do you think that just comes naturally, or do you think it's
Being
something that can be taught, or what?
the being proactive.
Mm-hmm.
I definitely think it could be taught and learned. I think just as myself as an example, I think at the beginning of my first ortho rotation, I wasn't as good as maybe 4 months down the road. Um, but I think just with practice and really kind of learning to quietly pick up as many details as you can with the residents that you're spending time with is definitely a trait that you can learn and get better at.
I think one thing that really stands out in regards to that is when you're setting up a patient on the OR table, you can immediately tell if someone has literally watched every single step that you just did and if they're able to reproduce it. So something that really stood out is the med students that would see, especially for a total knee is a great example. Everyone has a different setup, whether you're using a post, whether you're not using any post, like how you put the tourniquet on. Are you putting web roll on first and then putting the tourniquet on? Even small details about how you want the tourniquet hoses to point towards the patient's head, like towards the head of the bed, and not down towards your surgical field. Um, so maybe joints attendings get more focused on hyper details. But one of our attendings literally like even the way the comes down and is connected to the tourniquet. Like he says, it has to be draped on this particular item and cannot touch the floor. Um, so you, it's like hyper awareness to details and then being able to recreate it. And some of the students would be like, "Hey, mind if I set this up? I saw you do it. Mind if I try to tackle this?"
Yeah.
And um, I don't know. I think that shows a lot of proactiveness and anticipating and like taking notes, hyper engagement, hyper engaged, if that's a phrase.
Drew, one one thing I want to ask too is like the idea of being, how are you proactive and engaged without kind of getting in the way? That
Yeah.
was something that that was on my mind a lot. And what's the answer in one situation might not always be the answer in another situation. So kind of how do you approach that? Maybe I guess from an OR perspective and then outside of the OR.
I think I don't know if there's one right answer, and I don't know if I have the perfect answer, but I think as long as you're communicating, excuse me, what your thoughts are and what your plans are, that you can kind of gauge. It's that emotional intelligence factor of like, am I about to be in the way, and am I just gonna be not a helpful team member, or am I gonna take my kind of learning into my own hands and just go for it, and then read the room based on what happens after I ask. So I think if I had to go back and be a rotator again, I'd see how someone sets up the room, and then I'd literally be like, hey, I kind of saw how you do this. I want to learn how to do this. If we have time, do you mind if I just kind of do my best to just tackle it? And
Awesome.
then you can get a good sense of how the resident or attending responds, and they're like, oh yeah, go for it. More
Yeah.
power to you type of thing versus maybe not a good idea. And I would really, really key in on what the residents suggest, because sometimes they are watching out for you in regards to they know the attending is just like, let's just get this done, keep moving, um, and then they don't want you to be in a weird or awkward situation.
So I remember as a rotator, this would come up a lot, or like this question of, oh, how kind of in the situation should I be? A lot of times out of the OR, like kind of in an ER setting, a lot of the times I noticed, oh, I could probably get a splint ready here, or I know that they're going to want to get the X-ray machine and some lead ready. I would always kind of verbalize my plan as much as I could without kind of oversharing. Um, I just didn't want to be seen like I was like disappearing or that I was just sort of like venturing off. Because I knew that I was a visiting student. I was not a resident. Um, I'm curious on your thoughts on that, how to be, yeah, just kind of how to be engaged without, but, but kind of communicating, but yeah, good stuff.
I think it's one of the skills I try to teach more junior residents, and like when you're on call and you're not wanting to just call attendings and ask, hey, what do you want me to do with this? You want to call attendings and say, hey, I'm planning on doing this for this, this, and this. And then you kind of uh, sit, you wait. If they say cool, then you just go for it. So if I was a rotating med student and we were in the ED and I kind of got the hang of, I paid close attention to how people were setting up their splints, what they needed, where to collect the material, I would just literally tell the resident, hey, I'm planning on going to grab all this material and set up your splint, get the C-arm ready for you, if you're okay with that. And then
Yeah.
just kind of voice what your plan is, and then they'll either say yes or no. Um, and I think it would be a red flag if you were in that scenario and you went to tackle it and prove that you're learning, and they were like, oh, that's annoying. I think that would be
Yeah, because I guess you wouldn't want to be seen like you're disappearing or just trying to, yeah. But at the same time, you wouldn't want to not say something and just be standing there. Um,
which some people
because
do.
that can seem like yeah.
Some
So
people,
it really is a balance.
there's a huge balance because some people just kind of stand there and watch you work, and then they look like they're not engaged. And then other times people like really get the hang of it, and they're like, "Hey, I'm gonna go set this one up for you." Like, and
Yeah.
then It's for one super helpful. Two, it shows that you're really paying close attention to all these details of how these residents like their stuff set up. And if you can kind of put the whole room together, get the patient like over to one side of the bed for their distal radius and get your C-arm right exactly where you want it and all the materials ready to go and all the residents have to do is walk in there and crush it or let you crush it because you actually set it up, then that's like a huge win.
And then, kind of on that topic, and so some advice I got and something I saw firsthand is I feel like in the beginning, I always equated being helpful with like getting my hands in there and, like doing stuff. I felt like sometimes, especially in the emergency room when things are getting really busy, I felt like I realized and was told that sometimes the most helpful thing is maybe to just take a step back. Like I noticed if my resident was like really trying to like think things through or they were answering a ton of pages on their phone, um, that maybe, yeah, just learning when to like kind of maybe distance yourself and just instead be ready. I'm curious on your thoughts, Drew, on that, or what kind of situations that could come up in.
I think you bring up a really good point. Um, there's times where, and you guys will all experience it one day when you're in the teaching position as a resident, that it's very hard to keep track of everybody involved and it's hard to do it efficiently, and especially when you're getting blown up and super stressed. Um, so, in those moments, I think what you said with just really focusing on putting the med student putting their self in the position of the resident, being like, what would I want in that scenario? And sometimes it literally is just let me be silent, observe, be helpful where I can be. I think uh, med students can be more helpful than they think they can, even without doing or talking or anything. But they're if they're paying attention, writing things down, like the resident's like, oh well, I need to put the X-ray orders in for this. I need to specifically check on those X-rays after they're done. As a med student, you can just stand there, write that down for this so and so patient, and then you're like an extra brain that's helping remember the difficult things that can be easy to forget when you're kind of in an intense situation. But yeah, you're
Yeah,
exactly right. Sometimes, literally, the right answer is to just be silent and to put your head down and just work.
yeah. I would always have like a little notebook or something to write on, like as I was going, like just something that can kind of fit in your scrub pocket. I think was like pretty helpful and something I'm happy I did, like on rotations.
I think the next bullet point I have here is always be available and eager, but listening to cues. I think that covers exactly what you just brought up. Um, because sometimes the cue is residents say, you did a good job. You should probably just go home and take a break. And I would, I would take that, when residents tell you like, hey, you just need to kind of go home and recoup. I would take it at face value. And truthfully, if the resident is trying to test you and be like, oh, well, that dude's lazy because or gal, whatever, told them to go home and they didn't go home, and that's great. No, I think, I, I think that'd be very strange if someone told you, like, hey, you did a good job, go home, rest. I think they actually mean that when they say it.
And it was like a test, you're saying?
Yeah. Half
Was
the
it gonna
time
take
you
the
always
bait?
think
Yeah.
someone's testing you
Yeah.
or
Yeah.
they're like I had that happen when I rotated. Um, Actually at the program I ended up in Grand Rapids, where the dude was like, the chief resident at the time said, "Oh, yeah, just go home early." And I was like, "Are you sure? Like everyone's still working. Like, you want me to go home?" In my mind, I didn't really know what to do with that. I didn't know if it was a test or I think, what did he say? I think he said, "Don't come in tomorrow."
Oh, wow.
Yeah, I think he said something like
Okay.
that, like just take the day off tomorrow. And I think I did. I was like, okay,
Wow.
you told me to take the day off. I'm not gonna like be like, no, I'm not gonna take the day off.
Right, because I guess if you did show up the next day, what kind of message it says like, oh, I don't know if Drew can follow directions.
Yeah,
That's
there's a mind game
yeah,
there. Which is the right
yeah.
answer, Jimmy? I don't know.
Yeah, I guess I would take the day as well. But I like you, I would also sit there try to compute what just happened.
Yeah,
But
it's
that's
hard. It's
funny.
hard to know sometimes. The
Yeah.
next point I have is ask coordinators about who you will be working with ahead of time. Yeah.
Uh,
Did you do that before you were away?
So I did try to get a sense of what attendings I'd be working with on certain services. Just it's amazing what you can find online. Most hospitals will have like a page with the attending, and maybe some background about them. Um, that's pretty helpful. Sometimes it'll even say kind of their practice interests, like specific things that they see a lot of, or certain patient populations. So that can be helpful for prepping. Um, it's also kind of helpful to know what residents you're working with too, I think. And a lot of programs also put that information on their website as well.
And that's something like people shouldn't be worried about reaching out to coordinators and being like, "Hey, can I please have this information?" And that goes from all the way from a ways to interviews. And that's something I don't think I did very well as a med student. I did not proactively reach out and be like, "Hey, can you please send me a list of everyone I'll be interviewing with?" And then I think people should be going through every single person and then seeing what their research is, where they went to school, where they went to their training, and so on and so forth, to try to really almost like preliminarily build relationships with these people so that you can immediately, for one, recognize who they are. I can't tell you how many times I went in an interview type of pre-interview dinner, even for fellowship, and someone would introduce themselves. They'd look super young, and I didn't. They looked a little bit different from maybe the picture that I was used to seeing, and they introduced themselves, and the name didn't click right away. And then I say something stupid like foot and mouth of, "Oh, my name's Drew. Where um, what residency are you coming from?" or something like that. Something really dumb, Jimmy. It
But no, hey, I
shameful.
I mean I
And I'm
get it.
like,
I'm sure I did. I'm sure I said something along the way too. It's just um, yeah. Would you like? I guess if I did get sent the list of people who were interviewing me, I would look at that. Um, but I guess sometimes it wasn't always available. But I think that's great advice to just reach out to the coordinator. I think I was probably, I didn't want to seem annoying or
yeah.
in the way, but I think that's a great point.
And I think it's easy to feel that way. You're like, oh, I don't want to
Yeah.
step on any toes, but I feel like I always want to empower med students to be like, hey, you're a physician, like you're an adult, like you're gonna be the boss one day, and you just have to step up and do whatever it takes. And part of that is just not always being worried about every single detail of what you think the rules are. So thinking outside the box, being like, oh well, I'm going to be interviewing with a huge number of people in the near future. I need to figure out who they are, like as soon as possible. How do I do that? Well, reach out to the project or the residency coordinator, and then just respectfully ask, like, hey, do you mind sharing this information? So these are things like, I mean, that's a perfect example of if you don't have someone in medicine playing the game that has played the game that is helping you every step of the way, like coaching you, then it can be easy to miss like really, really important things. I think I missed them. I didn't do that. And it actually, fun story for people at Henry Ford, if anyone's out there listening, Noah. I interviewed at Henry Ford, and there was a guy there. Won't name any names, but he went to the same uh, med school that I did, and he was like, "Oh, how is so and so doing from this med school? I'm like, how do you know that person? And then he immediately went into, oh, you don't know who I am. Like, you really should have looked ahead of time. You need to know who you're interviewing with. And he kind of like scolded me right on the spot, which, yeah, I felt bad about, but I think it was good feedback. Like, I should have known like who that guy was and should have known that he was alumni, and that in my mind that I was going to be able to connect with him on that commonality in the interview prior to even being there. So
You're right. That would have been a, yeah, that's tough. But
it seems obvious after the
yeah,
fact. And now I'm like, oh,
it's
shoot.
not. Yeah, you told me that earlier, and I was like, wow, yeah, that is helpful. Um,
Anything to add to that?
no, I think those are some great points. So,
The last point I have in this section is be genuine. You can tell when people are just playing the game.
what are some ways that I guess you feel that comes out? For me, I think it's when people like ask questions. I'm sure I'm guilty of this too, because like you want to seem engaged and ask a question, and sometimes you're like, I don't know if I have to like kind of try to come up with one, but I don't know. I think trying to ask good questions, thoughtful questions that you've thought like really like put time into. I think that shows that somebody's being genuine to me.
Yeah, I think you can tell in the question arena when people are forcing it and how they respond to just normal conversation. And I think part of it is just can you have a normal can you are you easy to talk to, and can you have a normal conversation? And some people will you will you know maybe I'm prone to this more than most, but I will just be say something like really real, almost vulnerable, and be like, man, this has been really difficult to learn this particular step, blah blah blah. And then the response from the med student would just be something um, that just didn't feel realistic or genuine. It was just kind of like, it's hard to explain. Do you know what I'm talking about?
Definitely, yeah. And I think I don't know if this was going to come up later too, but something I wanted to talk about was how do you come across as friendly and genuine, which is a great word, without being too comfortable, because I uh, I think everybody will encounter this kind of on the trail, but like you get to know some of the residents really, really well. Like at some of the programs, I literally would work with the same person every day, 16 hours a day for like at least 2 weeks. So you get to know them super well. Um, but at the same time, you it's just important to, I think, remember that like you are still on rotation. You're like a visiting student. It's kind of like a long interview. At least that's what I was told, and that's kind of something I tried to keep in mind. Drew, I'd be curious on your thoughts, kind of from the med student perspective, and then also from the resident perspective.
At least from what I've seen, it seems like residents are looking for people that they can work with for 5 years, and that people that are genuine, hardworking, have baseline good character, because really you can't teach that and you can't change that. Um, but when um, when you're looking at that and the whole picture in regards to rotators, um, you just want to be sure that people aren't you're I'm kind of blanking and having a hard time discussing this, but
Yeah, it's a tough. Yeah, it's a
um, it's something that it's because it's like a huge interview process over the course of a month. So you're just trying to get
Yeah.
a sense of who people really are. Um, and how do you come across as genuine without being too buddy buddy? At the end of the day, like you said, it's a balance. Um, and and okay, so and this is tying into what I was saying with regards to um, being genuine. This and I've seen it happen multiple times. Sorry, guys, my mind is literally like mush right now.
No, it's
Um, so it it's very easy to let your guard or professionalism guard down. Um, so you, from a day to day perspective, you're what's the rule that was it Noah was talking about? Um, where the first week you don't say anything, the second
oh
week
yeah.
you say a little bit more, the third week you're like, okay, this is where you let your guard down a little bit, fourth week you shut up again.
I've
Um,
heard that. Yeah, that's funny.
I think there's a lot of truth in that, but you're showing who your personality is with also being respectful and never letting it cross that professionalism barrier. Um,
Right.
and I have seen it turn into where med students get really, really comfortable, and then it starts that relationships start interaction starts getting awkward because a med student will all of a sudden think that okay, I'm a part of the group, I'm on the inside, and um, and then the residents will be like, well, actually, you haven't suffered with me in the trauma bay uh, for 10 weeks straight
Yeah.
for a year, and the relationship just isn't on that level.
So some advice you would give is just kind of maintain that professionalism, but also I feel like the tendency, like you wouldn't want the pendulum to swing too far and somebody to be like cold, because to say like, oh, I have to stay professional all the time. But I don't know. I feel like the theme of today's talk is just it's a balance. It's that kind of thing. It's that fine line in the middle, and the answer at one moment might not always be the answer at another, and it's difficult. And I think
Yep, that's a really good
when you
way to
brought
say
up
it.
yeah when you brought up this topic for tonight, I was just kind of laughing because I just remember thinking about all these different questions last year a lot. So, and you can tell I'm still working through a lot of it. So,
Yeah, that's a perfect way to say it. I mean, today we talked about like the dichotomy of leadership and how like everything is a balance because you can't take it to the extreme one way or another. Like you can't just be full on buddy buddy and be one of the bros or one of the gals in some residencies, um, without sometimes taking it too far. But you also can't be too quiet and aloof because then people will be like, hey, like, are you going to be that person that I want to work with for 5 years, that I want to kind of
yeah.
suffer with for 5 years? Um, so
And
great way to
that
great.
last point about working for 5 years, I remember, I think somebody told me that last year, and it really kind of like sort of changed my frame of reference a little bit when I thought like this program, they're going to be looking for somebody to work with sometimes, in the middle of the night for the next half decade. Like, that's a really long time, and these programs are taking a kind of a not a gamble, but they really want to make sure that you're somebody that they want to be with for a long time. And so I guess that was kind of a helpful point, and I'm glad you brought that up because I'd forgotten that. Um, but yeah, because residency is a long time. Ortho residency is a long time. So
Half a decade.
yeah,
It's a long time. It makes your brain turn to mush by the time you get to your fifth year. So the next kind of category here is OR etiquette. Um,
yeah.
so before going into all the details of these notes, Jimmy, what's something you think someone what's an example of something you don't want to do?
I don't want to do. Um, Definitely So I think as a medical student, I thought a lot of the OR stuff was going to be like in the surgery, like how am I gonna, be helpful in the case? And there is a lot to that, but I think there's a lot to do before the case too, and that's where a med student can really be helpful and stand out. Just to name a few examples, I think Drew, you had shared a few of your points with me, like looking up looking up the images ahead of time, introducing yourself to the patient, getting in the room, and making sure materials are ready, those kinds of things. And we can kind of dive into each of those a little bit more. But yeah, that was one thing. If I could kind of go back and tell myself, hey, this is an area that you're really going to want to pay attention, it would be kind of in the lead up to the case.
Yep. And it's not obvious. So as a med student, I'd always ask, what should I be reading? And people would say orthonetters. And then I went and bought orthonetters from Amazon. And I remember opening that book and being like, okay, I'm about to be in an ACL. What do I read?
Yeah.
And it's like, well, just memorize all of orthonetters. I would say that's a bad approach. I think if I had to go back and redo it, I would be trying to get my hands on a PDF of an operative techniques textbook that residents at a resident level. My opinion is you never have to wait to read at whatever level you want to be at. So
Awesome. Yeah.
if you're an undergrad, even as far as I'm concerned, like, and you want to like push yourself to just learn the language, be be that much more willing to just pick up textbooks that people are reading at whatever level you want to be at. So for med students, I always tell them read these operative technique specific textbooks because those uh, chapters will go in step by step of okay, you make the incision here. This is how to find that specific incision site. Then this is what layer you're going to encounter. This is what nerve or vessel is going to be in what position that you have to be careful of. And then you'll encounter this nervous plane between these two nerves, and then you'll hit this muscle, and so on and so forth, to where
Yeah.
you'll be better equipped to anticipate the questions you're going to be asked based off of those textbooks because they even go into indications when you should be doing this type of surgery, what anatomy is there, what's the history of it, um, what are the pearls and pitfalls you need to be aware of, what's your post-op protocol. I mean, literally everything. It's just something I didn't realize even as an intern or second year of residency that some of these textbooks are so detailed in a good way, in a way that you can very specifically learn what these people are about to ask you ahead of time. So I call it surgery specific anatomy versus just like all anatomy or all ortho anatomy at once.
So in terms of the questions that you get asked, Drew, I felt like as a med student, the ones that I got asked the most were, first off, it was kind of in the early part of the case. So during like the initial approach, um, that it just seems to be that's when the lion's share of the questions came, especially the anatomy questions. Like, and the ones that I got asked were a lot of like what muscle plane are we going through, like what muscles are we looking for, sometimes what innervates each of those muscles was another common one. And then I'd say probably third was like what dangerous structures am I looking out for, like you had said, like surgery specific anatomy. I never really got asked like, oh, tell me the nerves in like this whole area. It's more like what are we thinking about in this case.
Yep, exactly. That and what random, very obscure 90s song is this and what band played it in what
Yeah.
year?
Music trivia is like actually pretty high yield in the OR,
It
I would
is
say.
super high yield because people are like,
Yeah.
hey, does this med student get me as a millennial soon to be attending or attending that's like, I just want to relive my days in the in the late 80s with my punk bands that no one knows about.
And so one other point that I just didn't want to forget to mention was I uh, I looked up a lot of videos on YouTube and online. I was pretty surprised at the amount of information out there. A lot of really good like animated videos for looking at approaches or surgeries, even some kind of like intra-op images or videos. One example I remember, this was when I was at my home med school. I had a shoulder. There was going to be a shoulder case, a shoulder arthroscopy case, and I've gone into netters because that's what I used through anatomy in my first 2 years. And I just studied all the structures and looked at everything. And then when I remember when they put the scope in and I was looking at stuff, I had no idea what was what. And they were asking me questions. And I remember I was not doing great, or well, I was not performing at the level that I felt I prepared to. And so what I started doing is I would look up, you can just look up like arthroscopy images or stills online, and they will label the structures for you. And I felt that was incredibly helpful. So, yeah.
Yep, that's a perfect example. There's a lot of pretty helpful YouTube videos, but truthfully, some of the time the YouTube videos aren't super helpful, and they're hard to find like which ones even on like platforms like VuMedi. Sometimes they don't always list all the things that you'd find in a textbook, because they're maybe more focused on the product or more focused on how to place the implant versus what does this structure look like, what innervates it, that type of thing. So I would do a
And
combination of all those things.
and Drew, when you were a med student, did you always have access to Epic before a case? I feel like something you're always asked is, hey, did you read up about the patient or did you look up the images? How would you kind of approach that on your ways?
I think I think you need to ask that. This is another thing that I think you should be asking the project coordinator way ahead of
Same.
time. I keep saying project coordinator, uh,
we get
but
gotta
hopefully you get what I'm
designate
saying.
project. Yeah.
um,
No,
so you're asking these people like, hey, I really want to make sure that I have access to the EMR. If that is normal for med student rotators, I just want to double check that I'm contacting who I need to contact for that. And then usually they can put you in touch with someone, and you'd be surprised at how long getting people access takes. But I remember as a med student starting some rotations and I wouldn't have access 2 weeks in. And it's
yeah.
really a detriment because if you can read up about patients ahead of time, know their comorbidities, know why you're doing the surgery, the indications, the most recent attending note usually has like, this is why we're doing the surgery. These are the risks and benefits. This is what I'm worried about. And you
And
can look at the imaging ahead of time, and then you're literally light years ahead of the typical med student if you can do that.
um and I don't know about you, I would notice sometimes that even if I did have Epic access, that it would be a maybe like a private clinic patient, and oftentimes those clinics will use their own EMR that's separate from Epic, for example. So I couldn't get access to the note, or I couldn't get access to the imaging, but I would always try, and I would make a note on like I would always like prep a sheet with all the patients for the day, and I would make a note if their imaging was available or not, because oftentimes you will get asked by the attending or the resident, hey, did you look at the imaging? And you can then tell them, I tried, or yeah. So I thought that was helpful. Um, and then Drew, we had kind of talked about this maybe a month ago, but you were saying like it's super important to not just read the radiology report, but to also open it up and look at the images. So yeah, I think as a med student, I had not always heard that. I think it can be tempting to just read the report quickly, but
The sequence of events is you should open it up without having read the report, look at it,
right.
find everything that's going on in that image, and then read the report. because they can really help teach you things that you're missing. But I don't know how many times more than I can count, where the radiology report was inaccurate or missing very important things, where I was like, oh crap, that is going on. Example is an AO dislocation that the radiology said, oh, looks A-OK. A-OK. But AO was not okay, it was dislocated. So that's like internal decapitation, like separation from,
Wow.
occipital condyles to the atlas. And if you're not looking at that very consistently, um, it's very hard to recognize. And this radiologists are literal geniuses. They go into radiology because they're like a physics genius. But you'd be surprised about how impossible it is to find everything going on in an image when you don't have a clinical exam. So, truthfully, I never fault radiologists for missing stuff. I would be a horrible radiologist. Um, but you'd be surprised at how much or how helpful it is with you knowing what is going on with this patient, why they're in front of you, why you're seeing them, where they're painful, and then you can immediately get so oriented and dialed into what you're looking for in that image. It makes a huge difference.
Yeah, that's awesome. And I don't know, this is still kind of on the topic of like prepping for the case, but um, what advice would you give a medical student, like getting into the room before the case? Like, what's like a checklist of things that you would definitely want to do, I guess.
So I think this is a big thing that has stood out. Some med students, I'll say, meet me at so and so time in this room. Um, and then, for whatever reason, if I got delayed, I'd say, okay, well, don't let me hold you up. And, I'd kind of see what they did. Would they just wait in the room, or would they go introduce themselves to the patient, go to the OR, grab their gloves? So a huge trick is to go to the sterile core at whatever OR you're at and be like, hey, grab your gloves for the whole day, like 5 or 6 pairs of double eights, whatever you are, and bring them to the OR so that the scrubs don't even have to like work at all to figure out what your gloves are. And no one's collecting your gloves for you. You are. Um, and then you're going to the whiteboard and putting your name up there with your glove size so that everyone knows who you are. You're introducing yourself to the staff. You're super respectful to everybody. You're pulling up the images ahead of time, if available and you have access. It's ideal if you do. And then you have everything, there and waiting, and everyone knows who you are, and you're just like dialed in, ready to go. You've already scrubbed your hands and your arms, um, and you're just ready to go without being told. Um,
Yeah,
I think that's a big deal when I see med students do that.
I feel like the whiteboard thing is a great one. Like, that's a small thing, but it's like your name is on there, and it's like projecting that you are prepared and that you showed up.
And
That's a good feeling when they say, "Hey, could you write your name up there?" And you go, "I already did."
yeah, I already
That's
did.
yeah.
And then
Um,
what I think taking it to the next level is like, hey, I'm getting my gloves, so and so resident, can I get your gloves for you? What size are you? And then you're kind of
yeah.
taking it to a next level, like how do I make your life more easy or easier for you when you're coming through? So
It's something I would do, and I still do, like so like at the start of the day, like introducing yourself and everything. But even then, between cases, as the scrub tech is setting up, I'll go like, "Hey, can I grab anything for you?" Even if it looks like there's gloves there, because I'm surprised. Like a lot of the times, I can maybe grab an extra hood, or we're missing a battery, or we do need an extra glove for something. So that's just something I would do. It's quick, and I just do it between every case. So,
so let me go down this list here really quick. We have OR etiquette. We've probably covered a lot of these. The first one I have is ask the best way to view what surgeries you will be doing the day before. or ahead of time. Be prepared, study surgery specific anatomy. We talked about that. Watch how it's done, then ask if you can set up next time. Take notes and then do the setup, pull images up ahead of time. We talked about going to the sterile core, getting gloves for the whole day, offering to grab gloves for residents, helping techs, meeting patients, introducing yourself, taking notes from the chart to know their comorbidities and stories of how they got there, knowing your surgical indications, putting your name on the board, glove size, stay focused. In long surgeries, if they want you to hold a retractor, you be the best retractor holder you can be. I think, this sounds obvious maybe, but you can tell a lot about someone when you give them a boring job. And that's not something I realized as a med student, but I think one of the best tests you can do for a med student that's working with you is hand them the scissors, and you can really tell if someone is dialed in with cutting suture. And you can also tell when med students think it's a boring job. They're like, "Oh, you're just having me cut the sutures. Like I'm a wizard at these suture scissors." And then you
They're
know,
hard sometimes.
and sometimes I'd say rare. I'd say it's rare because you'll notice, especially if there's two people suturing, you'll get your knots tied, and then you'll hold your tails up to be cut, and they're just so focused on the other person tying, they stop paying attention to you, or they got completely distracted. They're off in their mind thinking about something else, and then you're literally having to ask like, "Hey, please cut the suture." And you'd be surprised at um, how people react to what they think is a boring job. And I'm probably guilty of that. But there's a lot of nuance to like how long do these residents want this suture cut, depending on where you're suturing. And maybe we should. I mean, it'd be interesting to do a write up just like on a guide to cutting suture,
Yeah.
because if you're sewing on the hand with nylon, you want it a different length than if you're sewing on the hip with um, monochrome or something like that, or just doing simples on a hip closure versus simples on a palm or a hand. And there's lots of nuance there, and you can tell the med students that are really dialed in. They know immediately what length to cut that so that that tail isn't going to get in the way of your next suture, and you don't have to ask them, and you don't have to wait. So um, it makes a huge difference. I've gotten to the point where I will hold the scissors in my hand, my needle driver hand, because I hate waiting for people to cut my suture. I don't like saying it every single time, and often the scrub techs you're with they'll be off doing something else, and they think they can react fast enough to turn around and cut your suture while you're waiting that extra few seconds, which can get really frustrating.
Yeah. Great points. I don't, I think we covered everything I had for that, but there's one thing you had mentioned, Drew. I don't know if you had more points on the OR, but like the giving lectures on an away rotation. That was something I did not know about before going in to an away. Just for the kind of the younger med students, that there's no like shelf exam when you're on an away rotation, so there's not really any yeah, any like big test. But for every place that I went to, I had to give a presentation at the end. Drew, I don't know if your experience was the same, but
Not every single one, but it was common,
yeah, sometimes even more than one.
really.
But yeah, and almost like what they did vary on kind of the content. So one I remember was more of like a tell us about yourself, um, some of your interests and stuff like that. And then others were more, I would say more commonly, they were tell us about a case that you saw, and try to pull up like some articles or some background about that and kind of walk people through it. Um, So yeah, that's something I did not know was a thing, uh,
So,
kind of
what's your
before
biggest
starting my
advice for
class.
people giving lectures to residents?
So a couple things, I guess. First off, it's helpful to ask the residents, like kind of right when you get there, like, hey, do you guys give a presentation? Because if they say, yeah, you'll give a presentation on a case that you see, it's helpful to know that early on because then you can kind of keep an eye out for a case that you might be interested in presenting. Um, I think when you do find a case, then what I would do is I would ask permission from the attending and the resident in the case if you can present that, because I just think it shows
It's respectful.
it's respectful, yeah. Um, and then sometimes at some programs, the resident who you're in the case with will want to review your presentation beforehand. I had that happen at two programs. So you don't want you don't want to get up on presentation day and show that you're presenting something and surprise the resident who's in the case. That would not be good.
Yep, that's a
Um,
really good point.
yeah. So and then I think when if you are giving a presentation on a case that you saw, sometimes the operative report can be really helpful. Um, I noticed like the attendings maybe a day or a couple days after the case, they'll put in a um, kind of an operative report, which is a description of everything that happened, and that can be pretty helpful too.
One thing I
Those are just sort of
notice, yeah, that's a really good point because the op notes are probably one of the most helpful pieces of information because they go into oftentimes the indications for the surgery, the timeline, and then literally every single detail of what was done. And then sometimes people even put their post-op protocol plans in. Um, so super important piece of information. Something I noticed that some med students have done, um, and these were actually like high-powered, super intelligent, great rotators, but that maybe isn't a great tactic is when they're presenting, they started kind of pimping the room, and it's just resident. They're not pimping other med students; they're pimping residents and attendings in regards to kind of that Socratic method of like, let me ask you a question and then teach based off of your answer. I would say it's probably safer to teach in that style with people on the same kind of level of training. So if you're a med student and you're teaching other med students, I think that's great. If I'm a resident and talking to attendings, giving a grand rounds lecture, I don't commonly go to my let me pimp the attendings and teach in that mode. I don't know. What do you think about that, Jimmy?
great advice. I have nothing to add to that. Yeah, good advice. Like I think it would even, I guess you could ask questions maybe to somebody on your own level, but yeah, I never saw that as a student. So
Oh,
call
hold on.
your other med student gets
Sorry,
it.
I lost your voice there.
Oh yeah, am I back?
Yep, you're back.
I was just thinking, even if you were to ask like another med student a question, they could get it wrong, and so that wouldn't look super fun for them
Or
if
yeah,
they
if
get
you're a
that
med
wrong.
student and you ask an intern like Dr. Gannon, like, and then the med student presenter is like, actually, no, Dr. Gannon, you're not right on that. How'd that feel?
I wouldn't feel great.
It'd feel bad. I would.
Yes.
Everyone in the room would be like, "Ooh." So I
Um,
think we're running out of time, but I wanted to kind of put my list of how did the best rotators stand out, and this is the one I came up with. And feel free to add or subtract to this, Jimmy.
yeah,
So the first one I have is fun to work with, easy to talk to, genuine,
yeah,
like we talked about, anticipated well, was able to see what needed to be done, and then they communicate their way through it, setting up splints, setting up patients in the OR, so on and so forth. Followed directions very carefully, so um, even simple tasks, it's very easy for things to get lost in translation. But if you say, I want you to do this, then this, and this, and this, You better listen really closely, because sometimes that is a test. Other times it's not. People aren't trying specifically to like screw you up, but it's really important to be able to follow detailed instructions. Um, so another thing is when medicine rotators were proactive about saying their plan, running it by their authority. They didn't wait to be told what to do. We kind of covered that, or at least didn't they didn't wait to be told what to do all the time. They didn't just kind of twiddle their thumbs and wait to be told, "Hey, you should be doing this." They were always trying to figure out how to be helpful on their own. Interested in learning and easily engaged, well prepared even when it was very difficult, especially time when you had a time constraint, and then just basic respect for all staff, coordinators, coordinators involved as well. Anything you'd add to that?
That's an awesome list. I wouldn't change anything about that. I think, yeah, if I were to kind of go back and tell myself, what to expect, I think, like we were saying, it's just sort of riding that edge of being, you know, friendly and genuine without losing that professionalism, being engaged and attentive without being overbearing, and then being helpful without being in the way. Just kind of finding that balance and sort of accepting that maybe that it's going to change situation to situation. And I think that's kind of the art of the away rotation and being a good rotator. Um, yeah, that's kind of what I would tell a young Jimmy.
Nice. I think that's all good points, and I think that's all the time we have for grand rounds. If maybe one day in the future, if you guys are Jocko fans, Jocko always talks about his products that he's peddling at the end, like Mulk. So, Jimmy,
Not familiar with them all.
until we get our equivalent of Mulk, um,
Our
our
supplement for
our our,
rotator.
our white label
Pro-
supplement for rotators. In the meantime,
yeah.
we'll just talk about our what we've called or what I've called the Atlas course. It's essentially me trying to distill all this information into one place for people to reference things I wish I would have had, that would have saved me a lot of headache. A lot of this money, at least for the course stuff, goes towards like file not file hosting but website hosting, so on and so forth. So that's all I'll say about that until we get a better mulk. Jimmy, keep your eyes open so we can
For sure. Yeah.
peddle some good products.
Some protein shakes or something. That'd be good.
What we should do is let's open the platform for questions if anyone has any. I haven't seen anyone raise their hand or put comments in the comment section. But before we officially end, let's make sure there aren't any questions. There's even more details about what people like would need to know, like who to ask for a letter and so on and so forth. Like we won't necessarily dive into all of that, but if you guys do think of questions in the future, feel free to drop them in the chat, um, public chat or wherever, and we'll just keep plugging away, adding more helpful things, and trying to answer those questions. Looks like we have a couple typers.
You're welcome, Noah.
Noah says, "Thanks for the talk, Drew and Dr. Gannon. Great stuff. Love that. Made my day." It's actually um, podcasts are a lot of work. Dr. Jimmy, I think, is on call for the next 7 days straight.
I think I get one day there, so it's not straight.
How did that happen? That's what I want to know.
I had some PTO time, so
That's what you
Totally self, totally self-inflicted.
that's what you get. That's what you get for taking time off.
Oh, looks like Sebastian put in a question.
It's always helpful to residents. This is what Sebastian says. It's always helpful to residents when students write up or can that slow you guys down having to review what we wrote versus you just writing it out for yourself. I always find it pretty helpful when med students are kind of um, working away at the HPI during an interview, and then I can just go back in my consult note and be like, "Oh, yep, that HPI looked great. I'll copy paste that and put my plan in and exam and good to go." What do you think, Jimmy?
Yeah, I haven't had as much experience on this as maybe as I would need to answer the question, but yeah, I think certainly, like you said, if even just like I think you had said earlier in the talk, being that extra brain and just like listening in and just taking notes um, is always helpful. Always.
Yeah, Sebastian, I would say it is helpful. Like, um, you can't type and talk and examine all at the same time. So I think when med students especially are dialed in because they've worked as a scribe and they just go to town typing all the pertinent HPI uh, information as well as even some of the exam, then you're like, oh yeah, this is super helpful. Because documentation, I mean, uh, you'll see it here pretty soon, Jimmy. But when you're hitting 33 consults in a 24-hour period, and you round it on 20 people, and you have 50 notes to write, the notes that have things teed up in them are actually really helpful. Noah says should mention the goated rotation snack, Uncrustables. Here, I
There
need to
is something in those. They taste way too good.
wait. I need to find this. Oh, how do I find it? I might not. I might not find it in time, but Noah's comment made me think of a great meme. Quick, say something, Jimmy, while I'm looking for it.
Is it an uncrustable meme or I'm not familiar.
No,
What's that?
it's just like the meme where you're like, oh yeah, that's some good stuff.
Yeah.
Oh wait,
Yeah,
I found it. Here we go.
uncrustables at 2 a.m.
Here we
You're
go.
18 hours into a shift. I'm sure it's
There we go.
okay. You had sent that out in our residency wide email the other week, I think. I laughed pretty hard at that. It was great.
It's just so funny. It's Starship. It's Starship as a bundle of cigarettes. Well, I think that's a great way to end. Cool guys.
So
Thanks for showing up.
thanks for having me, Drew.
I'm gonna double check that this recording worked. If it didn't, that would suck. But if it did, I'll upload it and send it out. Thanks again for everyone being that was able to make it, and Dr. Gannon, thank you again for joining us.
Sure. Thanks, guys.
Okay. Have a good night.